Okay, we're going to begin now.
Did you hear the phone ring?
We're going to talk today about the heart, and in order to do that, we have to first get basic anatomy and basic terminology. So that's how we're going to begin. And I've given you several sheets of paper that we'll refer to, which will help, I think, to follow along with what I'm going to say. Now, the heart is an elastic, muscular volume pump that expels what comes into it in a pulsatile manner. It's elastic, it stretches. It's muscular, it's strong, and has great strength to it. It's a volume pump. Whatever comes in goes out. If it doesn't come in, it's not going out. You've got more, you need more comes in, more goes out. Now, pulse. We all know where the pulses are. We have a radial pulse here. Everybody can feel that. We have a brachial pulse here. That's what they use when they take your blood pressure. You have a carotid pulse up in your neck. Please don't feel your neck. You may stop your heart. And then you have a femoral artery in your groin that's as big as your thumb. And if you're in bed and you're wondering about your heart rate and stuff, that's an easy place to feel because it's quite large. So 3 places where you can pick up the pulse. The pulse. Now, we're going to talk about anatomy first. And I've given you a very crude schematic sketch on the first page with the terms that we're going to use that you should understand. The flow of the blood, the circulation of the blood through the heart is what basically we're going to talk about today. So, from the lower portion of your body comes all of the blood up the inferior vena cava. Inferior means lower, vena cava is the large vein. And it empties into the right atrium or atrium. The superior vena cava contains all of the blood from your head, your arms, and your upper chest. So the venous blood flows into the right atrium, passes through the tricuspid valve. Tricuspid, 3 cusps. And from there it goes into the right ventricle, which is the pumping chamber of the right side of your heart. And out the pulmonary valve and into your lungs. In the lungs, the blood is oxygenated. When the blood comes up into the heart on the right side, it's a deep, dark burgundy color. Goes through the lungs, the blood comes back to the left atrium through 4 pulmonary veins. The blood is bright red. It's been oxygenated. When oxygen combines with hemoglobin, the blood becomes red. From the left atrium, it goes to the left ventricle and out the aortic valve. The right valve, the tricuspid valve, has 3 cusps. The mitral valve is named after the bishop's mitral hat. It has 2 valves. And those valves are very important, which we'll go into in just a little bit. The blood goes into the left ventricle and out the aortic valve. And then into the aorta, which supplies your entire body, upper and lower body, with oxygenated blood. Now, take that schematic drawing and go to the next drawing, which is a drawing on a flat surface of a 3-dimensional object. More complex, but again, we're going to go through it once more. Look on the left side.
Which one are you looking at? This one?
Oh, this one?
This one.
This one. This one.
Page 3.
I have to look around for it, but it's there. The blood comes in the superior vena cava on the left on the top, and an inferior vena cava on the left on the bottom. Goes into the right atrium, through the tricuspid valve, into the right ventricle, out the pulmonary valve to both lungs. It comes back into the pulmonary vein. There's a typo here. The typo says pulmonary vein from the lungs to the right atrium. Should be the left atrium, not the right atrium. Goes into the left atrium through the mitral valve into the left ventricle, out the aortic valve, into the aorta, and out to the body. Now, any questions about that?
Many. You went too fast.
That's basic. That's what we're going to talk about. Now, we're talking now about the blood comes into the atrium, and the atrium is a chamber, and it fills, and as it fills with volume, the pressure increases, and the walls being elastic, they can move out. As the pressure increases in there, it pushes open the tricuspid valve and the mitral valve on both sides. Both sides are the same. And the blood then flows into the ventricle. The ventricle then dilates, and as it dilates with this volume of blood, its pressure increases, and the valves float upward. And then the ventricle contracts. And as the ventricle contracts, those valves are closed, and the pulmonary and aortic valves are open, and the blood flows out. As the blood flows out, it goes into the aorta and the pulmonary artery, which are also elastic vessels. They distend from the pressure and volume, and as the blood flows through, the pressure decreases, and the pressure above closes the pulmonary and aortic valve. So that's how it works. So what can go wrong? Well, an awful lot can go wrong. We talk about the valves first. The valves may malfunction either by leaking, which we call regurgitation, or by opening partially or incompletely, which we call stenosis. Sometimes the valve has both problems. It both leaks and is stenotic. The blood is in a leaking valve, the ventricle contracts, the mitral valve is supposed to close, but it doesn't, or it has a hole in it, or it's stretched, or it's out of shape, and the blood flows backward into the left atrium. That means blood, which is supposed to go out the aorta, is going up this way. That means increased work and force from the ventricle to get the blood going in both directions. And if the blood, if you're supposed to, let's say you're supposed to have 3 to 5 ounces going out this way, but one of those ounces goes out this way, that means the atria gets larger, and more blood comes in for the next beat, and the ventricle has to get thicker and larger in order to get that extra blood out. And that's the work that the heart does, can then cause the ventricles to fail. And that's congestive heart failure, and we'll get to that near the end.
You're using atria and auricle.
I'm using atria, I'm not using auricle.
Okay.
But
But
auricle
they're
is,
one and the same.
they're both the same.
Yeah.
It's just a different terminology. So the valves can be normal, they can be regurgitant, or they can be stenotic. Now the mitral valve, the one that has 2 leaves on it, is attached to the ventricle by strings, which we call cordae dentini. I won't get into that. They're just strings that attach to a papillary muscle which is contained in the wall of the left ventricle. Now think about a parachute with the strings down to the person who's below the parachute. The person would be the papillary muscle, the strings of the parachute are the cordae dentini, and the parachute itself is the mitral valve. And so that you can see that things might happen there. And you can have problems with the parachute, the valve itself. You can have problems with the papillary muscle that can be caused usually by heart attacks. Heart attacks that damage the muscle can also damage this papillary muscle, so that the mitral valve doesn't close completely and the blood regurgitates into the atrium, and you've got 2 problems. Problem with the ventricular muscle, problem with the extra blood in the atrium, and if you distend the atrium enough, you get an abnormal rhythm called atrial fibrillation, which is common, but there are many causes of atrial fibrillation. We'll get to that later as well. Now, in women, particularly in the United States, in women, there's a connective tissue disorder which is called a floppy valve, because this mitral valve degenerates, deteriorates, and its structure expands so that it's too big, and it flops up, and the blood comes from the ventricle into the atria through this floppy valve. And again, this is a common thing in women called mitral valve prolapse. I think maybe you've heard of that. Now, the mitral valve and the aortic valve are subject to damage in the case of acute rheumatic fever. And rheumatic fever is a disease which is caused by streptococcal sore throats, which can easily be treated with penicillin. And in the days of the early days of penicillin, now that we have penicillin, we don't see rheumatic heart disease in the United States much more. To try to teach a medical student what mitral stenosis sounds like, you have to search far and wide to find a patient that would be an example of that. One of the things we've improved upon as we go along. Now, let's talk about the aortic valve now. The aortic valve is probably the most important valve in the heart because it controls the function of the left ventricle. The aortic valve is three cusps, and the three cusps come together, and when the blood goes into the ventricle and it's ready to contract, and it does contract, it pushes the valves up against the wall of the aorta, like that. Just go straight up like that. And then as the blood goes through and into the aorta and the ventricle is emptying, then the pressure then causes the valve to close. So it's the flow of the blood that causes it opening and closing. And that aortic valve can have many kinds of problems. Aortic stenosis occurs very commonly in older people. The valves become sclerotic and they get calcified, and the opening, instead of being like this, can be as much as just a pinhole. And so the ventricle really has to work hard to get the blood through that pinhole out into the aorta. And these are the ones that can be corrected by a prosthetic valve or a porcine or bovine valve. And valve replacements now are very common, and it can be even done now without opening the chest. They can be done through an artery, much like you do when you put in a stent for coronary artery disease.
How successful is that?
It's getting more and more common. Now, instead of in the old days would be 1 or 2 or 3 years ago, they put the valve in through the femoral artery because it's that big. But now they're doing it through the radial artery, which is that big. And that's, to me, almost a small miracle how they can get something to put a new valve. Of course, the valve comes in, when they let go, it goes. But they can do it now, and they're doing it very successfully. All right, now, next, we're going to go now to the coronary arteries. And for the coronary arteries, I want you to first look at this one. This one. One of those pages. This one. Now, there are 2 coronary arteries. And the openings to the coronary arteries, the aorta is, well, let's get both of them. You can't get both of them at the same time because they're stapled to them. We want you to look at this one. We also want you to look at this one. And this one shows at the base of the aorta there are 2 little holes, 2 little circles. And these are the openings to the coronary arteries.
Here.
My very crude drawing. Okay. At the base of the aorta, there are 2 openings, the right coronary and the left coronary. When the ventricle contracts and the blood flows into the aorta, And then when the pressure in the aorta is greater than the pressure in the ventricle, the valves close. When the valves close, that's when the blood flows into the coronary arteries, right and left. Very important distinction that you get in your mind. The coronary arteries fill when the aortic valve closes. Now, and I showed that here. But the better drawing is this drawing on this side, which shows the right and left coronary artery. The right coronary artery goes to the right ventricle. The right ventricle is a low pressure pump. The blood pressure from the pulmonary artery is 40. The blood pressure from the aorta, or on the left side of the heart, is 120/80. Considerable difference between 40 in the pulmonary circulation and 120 in the systemic circulation.
What was it? What was the right one?
40.
Just one number?
140. And that's why you never hear of right heart failure or circulatory problems in the lungs causing problems on the right side of the heart, because it's a low pressure pump. It does 1/3 of the work of the left ventricle. So the left ventricle is most important. Now the left coronary, as you can see from this drawing over here, comes off of the aorta, and it's a short, very short segment is called the left main coronary artery. And that splits into two parts. The one part is the circumflex artery, which goes around to the back of the heart, and the other one is the left anterior descending artery, which is the one mostly involved in heart attacks, acute myocardial infarction. That supplies the front side of the heart, the front side of the left ventricle. Now, in that short segment, as it comes off the aorta before it splits into the two arteries, that's called the main, the left coronary main artery. And if that part occludes, then you can easily see how you can lose both the circumflex and the left anterior descending at the same time. And that's called the widowmaker, because that usually results in almost instantaneous or within a few minutes demise. So that artery is extremely important. Now down below, I drew beautifully four circles. The first circle is a patent artery.
What are you looking at? Oh.
Patent artery. There's nothing there. It's smooth, it's nice, it's clean, it's beautiful.
There's
Is
blood.
patent the same as open?
Wider. Wider. They're all open, but this one's wider. The next one shows a little bit of matter on the bottom of the circle, and that would comply with what's underneath it. If you took the vessel and cut it, and you'd see that there's a plaque on the lower surface. And that's just it is a plaque, and it won't really interfere with the circulation in the vessel unless something would happen to it, which we'll come to in a minute. The third circle is now this plaque is not just in one place, but it's all the way around. And so that you can have problems in any part of that circle. And the final circle is that you have a pinhole there for blood to flow through. And that emphasizes, well, let's say the third circle might be angina. I get pain in my chest when I walk fast or climb stairs or whatever. But this one here would be when you really have your heart attack, where the thing's either a pinhole or it is completely occluded. Now, how can that happen? Well, it generally happens because on this, look down on the bottom of this thing here. You see this one that has looks like a little mesa with a little black thing on top. That is the beginning of a thrombus. You get a clot. You get a clot on top of the plaque, and the clot propagates, and you end up with something like this circle over here.
And it moves.
And that would really cause major symptoms. and we're going to come to the symptoms. But I want you to get an idea about that. Now, what's peculiar about the coronary circulation? The thing that's peculiar is, if you look again on this drawing, you'll see that all of those arteries that come down into the muscle of the heart come to a point. They come to a point. They stop. And the reason is that the body is peculiar in that the heart vessels are end arteries. When you get to the end, that's the end. There's nothing else. Now, most arteries in the body have anastomoses, which are connections. Now, let's take your finger. You've got a blood vessel that runs up this side. You've got a blood vessel that runs up this side. But you've got a bunch of blood vessels that cross over, so that if something would happen in one part, the blood would go around up to where it's supposed to be. Not so in the heart. If you block up a vessel in the heart, all of the muscle distal to that blockage is going to die. And it's going to die rapidly. So time is of the essence.
Does distal mean on the far side of it?
Pardon?
What is
Distal means on the far side of it?
distal?
Yes, distal means on the far side of it. You have a vessel, it's blocked here, there's nothing going down there. So, it's essential then that we get to the person who's having a heart attack right now, quickly, hopefully within an hour. And we're going to come to that in just a moment. But I want to emphasize to you that these vessels are quite different than any other vessels in the body, because they don't anastomose with each other, which would allow circulation to go around. In the brain, it's different. The blood goes all over the place and circles and meets, and a lot of ways that you can increase the circulation in all parts of the body except in the heart. You can't do it in the heart. So let's talk a bit then about heart attacks. First, the risk factors. I'll run through these quickly. Smoking, diabetes, lipid disorders, high cholesterol, high low-density lipoproteins, high-density lipoproteins, high blood pressure, advanced age, being a male, excessive alcohol, and family history. They're risk factors. Symptoms. If a person says to you, particularly a man, I'm having pain in my chest, and he goes like this, you can bet your boots that that's his heart. You get a pain in your chest, which is a weight, a heaviness. Somebody is sitting on my chest, right here. And this pain can radiate. It can radiate up to the shoulder, down the inside of the left arm. It can radiate up to the jaw. Many people have died on the way to the dentist for a tooth when they were having a heart attack, right here. It can also radiate into the abdomen and give you nausea and vomiting. How many times have I told you that prior to 1925, there was no such thing as an acute myocardial infarction? The death certificates, everybody died of acute indigestion. It was Paul Dudley White, and all you young folks know who Paul Dudley White was, who coined the phrase acute myocardial infarction. Paul Dudley White took care of Eisenhower when he had his heart attack. So we have pain in the chest with radiation to various parts, sometimes vomiting, sometimes belching, sometimes abdominal distress. That's why the acute indigestion was called. 1/3 of patients do not have any pain. Women have atypical symptoms. Women are not like men. They don't get the degree of chest pain or even chest pain itself as an early symptom of a heart attack. They have more likely fatigue, a great anxiety, a sense of impending doom. I think I'm going to die. Shortness of breath, palpitation, and sweating. Sweating, of course, would indicate a drop in blood pressure, maybe an arrhythmia either being too fast or too slow. Now, how do we make the diagnosis? The early diagnosis is made by electrocardiogram, and that's why the paramedics would put an electrocardiogram on you right away. This is the normal electrocardiogram. You have a beep here, a thing here like this, and then a wave here. This is the P wave. This is called the QRS wave. This is the ST segment, and this is the T wave. That's normal. In a heart attack, this is normal, but this goes up and keeps going up, and can go up, or it can go up and come way down. And as soon as they see that, they know that you have myocardial damage. So it's easy to make a diagnosis with electrocardiogram. But electrocardiograms not always abnormal. So what can you do? When they take you to the emergency room, they will do a test of your blood. They draw blood right away. And in the blood, there are certain enzymes which can be measured. When heart muscle is damaged, it releases chemicals into the blood that can be checked very simply by a blood test. And these are called troponins I and T, or CKMB, which is short for creatinine kinase muscle and blood and brain. And these are 3 different chemicals that can be checked. So they draw the blood as soon as you hit the emergency room. They draw it 6 hours later, 12 hours later, and 24 hours later. And this measures the degree of heart damage that is occurring while you're waiting for something to be done. So, what can be done? Let's go to this one. A person comes to the emergency room with a suspected acute coronary syndrome, meaning probably has a myocardial infarction. They do a rapid history and physical, they do electrocardiogram right away, all done in the first 10 minutes. They put in an IV, they give you an aspirin to take, they give you oxygen, give you some nitroglycerin, and if your symptoms are persistent, they'll draw these labs, but they usually draw the labs before they even do the IV. If the heart attack is suspected, or if the heart attack is not suspected, and you can make a diagnosis, then of course you stop right there. But if you have a suspicion because of the electrocardiogram, then you go to the next step. And the next step is a beta blocker, which is a medication to slow the heart rate. Ordinarily, in acute myocardial infarction, the heart rate will be fast. However, if it hits a certain portion of the heart rate might be very slow, from 50 to 30. And under those circumstances, you would need a pacemaker quickly. But they give you a beta blocker to slow the heart rate. They give you a heparin, which is the clot dissolver. Give it to you intravenously. If you have a clot, like we showed in that one picture where the vessel was occluded, that might lyse the clot so that more blood could flow through. And they give you IV morphine if you need it for pain. And nowadays they'll start a statin medication if you're not already on one. Now, let's go to the right hand underneath that where it says ST elevation. ST elevation. What they do next is they send you to the cardiac catheterization lab where they do put a catheter into your femoral or brachial artery and run it up to your heart and get it at the entrance of your coronary artery and then take X-ray pictures to see where the blockage is and how extensive it is and what they should do. And when they decide what they do this primary percutaneous intervention, which is either dilating the area which is occluded, or which is stenotic, or they put in a stent Stent is like, the best way to describe it is like the ladies' rollers for their hair. It's got two things on the end and wire in the middle, which expands. You know, that's the best way I can think of trying to define a stent. It has metal in it which expands when you let it go, so that it opens up the vessel. Obviously very, very small. And of course, many people now are walking around with multiple stents in them. If they are unable to do that because you happen to be in a hospital like, let's say the Garden Grove Hospital in Orange County, which can't do that, then the people in the emergency room would give you Plavix, which is an oral drug to prevent blood from clotting, or they will give you an intravenous injection of a thrombolytic agent hoping to dissolve the clot. But then they'll put you right back in the ambulance and send you to a place that's equipped to take care of it. But there are a lot of places in this country that are not equipped to take care of it for this thing. Now let's go to the other side for a little bit. And you're not sure. The electrocardiogram is equivocal. You don't know, still patient has the symptoms. You're still not sure what's wrong. So you do these serial troponins. And as you go down the algorithm, oh, and I should mention about algorithm. Algorithms now are in all hospital protocols for many, many different things, because the insurers and the Medicare payers are insisting on the best possible treatments that can handle certain diagnostic categories. And so every hospital has a bunch of protocols for whatever comes into the emergency room. This is just a protocol for myocardial infarction. But they all have these protocols, and the hospitals have to follow them, because if they don't follow them, then they get dinged by the Medicare, and Medicare doesn't want to pay them. So they all do this very much the same. But let's say that you're equivocal. What do you do then? They put you on a treadmill, do a cardiac stress test, see if you have developed any symptoms while working, exercising, and then either admit you or do one of these percutaneous interventions, or ultimately discharge you on a medical program to be followed up by your own doctor. And I think this gives you some idea about what happens in just about every first-class institution when a patient comes in with chest pain or symptoms that they can diagnose as myocardial infarctions. All right, now, let's see what's next. Now, I want to go next to talk about arrhythmias. Arrhythmias, that's also what she did. Now, in that first page that I gave you, there's a little dot on the drawing. Little dot on the drawing in the right atrium. It says sinoatrial node. The electrical impulse for controlling the heart rhythm resides in the right atrium. The impulse starts there and goes down the interventricular septum, that line that goes straight down the center of this drawing. There's no connection between the right and left this way. When you're born, you have a patent foramen ovale in the atria, because in the uterus you don't have breathing. You use the mother's blood for oxygen. As soon as you take your first breath, that closes. So there's no connection between right and left. But the sinoatrial node is in the right atrium, and that's what controls the rhythm to your heart, and it's all electrical. So we have normal sinus rhythm, normal pulse rate, normal heart rate, 60 to 90 beats per minute. The resting rate over 100 should be investigated for either disease or heart problems. Disease meaning systemic disease. Heart rate below 50 or around 30 demands a pacemaker to keep the rate around 7. The ordinary pacemaker runs around 7. Now, premature ventricular contractions. This is the most common arrhythmia that we see. It does not require any treatment. Let me see if I can do something with that. Normal beat, normal beat, normal beat, normal beat, early beat. This distance is much shorter than this. This beat is premature ventricular contraction. This early beat is followed by a pause. This is the next normal beat, normal beat, normal beat, early beat, next normal beat. When you have premature ventricular contractions, you usually complain of either palpitations or my heart is jumping or skipping or I feel peculiar. You don't feel peculiar because of this beat. You feel peculiar because of this beat, because the heart is a volume pump. It pumps out what comes into it. So it pumps out 3 ounces, 3 ounces, 3 ounces, 1 ounce, 5 ounces, 3 ounces, 3 ounces. So it's the next normal beat that you feel that says there's something going on. This is very common and is not to be treated. Doesn't need treatment. Just something to be aware of if it happens to you. And it's very, very
serious.
No, it means nothing.
Ah,
It means nothing.
I've had it since I was 40.
It's an aggravation is what it is.
It's a Latin beat.
And now you're 80, you're doing fine.
Yeah, exactly.
That's the most common. All right, let's talk about tachycardia. Tachy means fast, fast heart. Brady means slow, slow heart. Bradycardia, slow. Tachycardia, fast. Greater than 100. If you have a resting rate significantly greater than 100 all the time, you should be studied to find out why this is so. If your heart rate can go up to 200 beats a minute. Paroxysmal atrial tachycardia is a very common type of tachycardia. It comes on suddenly. Can't give you a reason why it comes on. There's an irritable focus somewhere in the atrium that's causing this to occur. And it can be stopped by stimulation of the vagus nerve, by breath holding, which is also stimulation of the vagus nerve. It can be stopped by massaging a carotid body, which is a widening of the carotid artery at the angle of your jaw. Please keep your fingers off the angle of your jaw, because you can slow the heart, even stop the heart, if you do that, if you're sensitive enough when that's done. But if you're making a house call on somebody that has paroxysmal atrial tachycardia, you try to treat it right there rather than shipping them off to the hospital, which is not necessary. Of course, if you can't control it, then you've got to ship them off to the hospital. We can also use a medicine called adenosine, and then for treatment for prevention, they use calcium channel blockers like verapamil. A common one among us older folks is atrial fibrillation and flutter. Atrial fibrillation is a twitching of the muscle. Instead of the muscle beating, it twitches. But it also passes stimuli down to the ventricle. And so that in atrial fibrillation, the ventricle is usually going faster than it should be. So you have to control the atrial fibrillation or convert it back to normal rhythm. And you can convert it with electrical shock on the chest. You can use IV beta blockers or calcium channel blockers. People who have atrial fibrillation have a problem with their chronic atrial fibrillation all the time. The fibrillation allows the blood in the atria to become stagnant. And the atria has appendages, it has little things that come out from it. And you get clots in there. And if you get a clot in the left atrium, goes through the mitral valve, out the aortic valve, up in the brain, you've got a nice stroke. So you want to prevent that, so you give anticoagulants for people who have chronic atrial fibrillation. The common one in the past has been Coumadin, but there are several new, three new medications which are being used, and the literature, medical literature, suggests that these medications are better than Coumadin, but if you watch your TV and you see signs from the law offices, if you have been taking this medication and you had a stroke, you may be compensated for that. So there are questions about these.
You can die with money.
What?
You can die with money.
No, you can die in the winter. Anyway, they're irritable focus, and usually in the left atrium, and there are ways of treating this with electricity by burning, heating, destroying the tissue. There are cardiologists now who are called electrophysiologists. All they do is treat chronic atrial fibrillation by putting catheters up into the atrium and mapping the atrium for irritable foci and then destroying these irritable foci. Sounds very good, very difficult, not always successful, and there are significant side effects in a small percentage of patients. It would be a very difficult decision to decide whether you're going to treat atrial fibrillation by electrophysiological means, or whether you're going to try medication, or you're going to live with it. We talk about bradycardia, heart block, the rate below 50, approaching 30, use a pacemaker, or better, use a pacing defibrillator. As far as the ventricles are concerned, ventricular tachycardia is a rhythm which generally leads to death. The rate is usually over 200. The rate of 200 is not able to sustain the circulation because you can't get enough blood in the ventricle to supply the rest of the body when you're going at 200 beats a minute. And it often deteriorates into ventricular fibrillation, and when that happens, if you're not cardioverted within 6 to 10 minutes, you are no longer with us. And there are medications for that, and implantable defibrillators are also utilized. Now, finally, but one more section after this. The heart has its own intrinsic rhythm, but it is also controlled by other factors that are important to the body's stability. And one of these factors is the autonomic nervous system. You have two nervous systems. You have a nervous system that says, move your fingers. I move my fingers. And you have a nervous system that controls your heart, your breathing, your digestion, all kinds of things, which is in the base of your brain, in the brainstem. There's two sides to this automatic brain nervous system: sympathetic, parasympathetic. The sympathetic side speeds things up. The parasympathetic side slows things down. Sympathetic side raises the blood pressure. Parasympathetic lowers the blood pressure. And these are automatic. They occur. You get under stress, your heart rate goes up. You want to run up a hill, your brain tells your body he's running up the hill, increase the heart rate, increase the blood pressure, increase the amount of blood circulating in the body. All done automatically. But there's also hormones that can do this too, particularly epinephrine from the adrenal gland. These probably more on an emotional side. Things happen, cause you to feel badly about it. You get a more rapid heart rate, more increase in your blood pressure. But again, if that's a chronic thing, there are good medicines to treat that. Now, finally, I'm going to finish up with congestive heart failure. Congestive heart failure occurs in 5 million Americans and 300,000 deaths every year. Very great cause of recurrent hospitalization. And this is where protocols, algorithms are being generated all the time to try to keep people out of the hospital. You bring them into the hospital, you stabilize them, you give them the proper medications, you give them the right diet, you get their salt under control. You do everything you can, you send them home, and come back in a month or 2 months with the same thing over and over again. There's great efforts now in trying to find ways to keep people out of the hospital with chronic heart failure. And the two types of chronic heart failure, systolic and diastolic. Systolic is when the heart contracts, systolic. Diastolic is when it fills. Systolic is the inability to pump out the blood that comes in because the muscle is weak. And diastolic, the ventricular wall gets stiff and it gets inelastic, so it won't fill. It only gets a small amount, so it puts out a small amount because it can't fill. And in these circumstances, the blood piles up in the lungs, and you get pulmonary edema and shortness of breath. And that goes back to the right side of the heart, in which the blood from the right side can't get into the left side, and so that causes swelling in the feet, legs, liver, and then ultimately kidney failure. What are the symptoms? Fatigue, swelling of the feet and legs, shortness of breath. Sometimes at night in bed you can wake up because the fluid in the legs has gone to the lungs, and they cause you to have what we call paroxysmal nocturnal dyspnea.
Do that again.
Paroxysmal means sudden, nocturnal is night, dyspnea is short of breath. Medical lingo. Paroxysmal nocturnal dyspnea. Shortness of breath. So what do? You sit up, you put your legs over the side of the bed, and pretty soon you're better. Simple. Doesn't mean you need treatment. Try that first. That doesn't work, you call for help. All right, and I think that's all I'm going to say. It gives us 12 minutes to ask questions. Anything. Doesn't have to be hard.
And is it the, are you just working? And the advertisers of the pills, you don't have to take a blood test.
Yes.
How come you don't have to take a blood test? So you know what's going on.
Could you repeat the
Yeah, we couldn't hear
question?
him.
He's talking about the three medications. Odvar asked the question about people who are taking Coumadin and requiring blood tests, and the medicines that are now out, which you can take, which do not require blood tests. And as I said, the medical evidence thus far shows that the newer medicines are just as effective as the Coumadin. Probably more expensive. But also with risk. And the risk of all these medicines, including Coumadin, is bleeding, and particularly bleeding in the brain. So they all carry a risk. The question is, which one is best for me, and which one is has least risk? And all that will depend upon the experience of the person who's prescribing for you. And I've been asked many times, what about this? And the answer is, I don't know. I don't think enough time has gone by to be really sure. But when I see ads on the TV saying, consult this lawyer if you have this, when you're on this medicine, then I get a little shaky about that. But there are people here in this place who take this medicine and have done so successfully. The answer is, I don't know. But it's a good question. It's like all things. It's like all things that are new. It's like I told you before. When I was practicing, no medicine until it's been on the market 3 years. I won't use it. After 3 years, we think we've got a good idea about what its effects are, like side effects. Dan?
Well, you've heard this story, but I'll share it and you can comment on it. I know a man, that did a Coumadin for quite a while, and his doctor recommended shifting to plaques.
Oh, no, that's not right. That's not right.
Well, maybe not plaques. He said it's something other than Coumadin.
Yeah.
And when they did that, it caused very serious bleeding in
that's the point, but that's anecdotal. That's anecdotal. That happened to that person. But I want to know what happens to 10,000 people who are on that medicine 1 year, 2 years, 3 years. I want to know the percentage of those who have trouble and the percentage of those that think it's the greatest thing in the world. Again, he mentioned Plavix. Plavix is an oral pill that they use in every patient that has a stent put in for 1 year. That's to keep the blood from clotting up the stent. But that's a pill, oral pill. It has some risk, mostly bleeding in the stomach, but it doesn't carry the risk of Coumadin or these other medicines. I can't even pronounce them. Okay. All right.
In the case of Pradaxa,
Yeah.
which I was on at one time,
Pradaxa, that's one.
they say you can't use that associated with a heart valve failure or whatever. Why is that? Do they have evidence that says?
Yeah, if they tell you you can't use it, they have evidence that your risk is greater if you do use it.
Yeah.
It doesn't say something's going to happen to you. It
They
just
say
says
why?
the risk-
What the,
No, I can't give you a reason why. You got to remember now, I haven't done this for 16 years. I'm getting old and I'm obsolete. So, but I can talk about the basics, but I can't talk about. That's why I never talk about medication if I can help it.
And very few doctors agree.
That's right. That's right. It's the doctor's experience. It's your confidence in what he says. Am I going to the right guy? Yeah, you're going to the right guy. Well, then do what he's telling you to do. But when the guy says to you, take this medicine, what are the side effects, doctor?
Yeah.
If you listen to the TV, every medicine they give out, they got side effects running from here to here. They're out here. Anybody that takes that medicine's crazy.
And the last one is death.
Yeah. No, they don't mention death on
Yes,
the
they
TV.
do.
Yes, they do too. They do too.
You're right.
Okay,
I'll bore you with one.
5 minutes. Go ahead.
You and I have had multiple bypasses.
Yes.
How many bypasses can you have?
You can have as many bypasses as you have places that are blocked. Yeah, I've had 4 bypasses. But I say I had 4 bypasses 32 years ago.
Congratulations.
I'm alive. 32 years ago, 1982. That's what they say when they see me. How do you feel? I feel great.
Go away then.
But,
What are they, for something like this blood thinner, what are the protocols for testing it before it goes into clinical usage?
well, we
And
talked.
is there a balance there a judgment balance that's difficult to strike?
It has to be approved by the FDA. The FDA, we talked about that. Phase 1, phase 2, phase 3. Phase 1, animal studies. Phase 2, toxicity, and so forth. Phase 3, 1,000 patients. 5,000 patients. The statistics, how many had this, how many had that, and then they either approve it or they disapprove it. If they approve it, then it's for the majority of people, it works. But there's always that minority in which it doesn't, or you get significant.
And they also, I was reading today about a meningitis outbreak, and they vaccinated 91% of the students at this university with something that's not approved for use in the United States, but is in use in Europe, but the Center for Disease Control said they could use it in this special case. And
I'd be leery about that. I wouldn't want my kid.
so just having a test, European standards are lower, higher?
No.
Or just different?
No, they're just different, but there's nothing wrong with the European standards. I won't say that that's something. I only know about what we do here, though, in terms of trying to make sure things are safe before you let them out in the public. But they make mistakes. And when we talked about diabetes, I told you about the medicine that was put out in 2003 was taken off the market in 2008. They just found out. It took them that long to find out this wasn't the right stuff. Nothing is
And if they
perfect.
would vaccinate their kids when they're supposed to, we wouldn't have all this.
Everybody's on baby aspirin, they ought to be on baby aspirin. Baby aspirin is very good for preventing your blood from clotting. And certainly anybody who's had any circulatory problems, heart problems, especially anything, but how many, let's put on heart. How many people in the room are on baby aspirin?
On what?
Baby aspirin, 81 milligrams.
I take regular aspirin.
Yes.
Does it lose its effectiveness after time, over
No,
time?
no.
If you're on an anticoagulant, would you need to take it?
Pardon?
If you're on an anticoagulant, would you,
No.
you don't need to take
No,
it?
no.
I did up until
I wouldn't take aspirin if I was on Coumadin, no.
No.
I'm on Coumadin, and my cardiologist says baby aspirin 3 times a week, and I've been eating that for years.
There you go.
What do you say?
81 milligrams 3 times a week, I don't think you're doing anything.
Yeah, that's pretty weak.
Yeah.
I don't think you're doing, okay.
Have to get him,
All right.
get him off his back.
Thank you very much. We're done.